Let's see. Okay. So we are live. And I'm gonna do a little bit of topics. These are all the topics that I need to cover. And before that, let me finish off my project right here. So yeah, we have anti-TB, bronchogenic drugs, pneumonia, lung abscess, and embolism to go to. Okay, let's continue. So pneumonia is accelerated solidification of lung tissue. Classification: you have community acquired pneumonia and healthcare acquired pneumonia. Community acquired pneumonia occurs in community or less than 12 hours of hospitalization, and healthcare associated after 12 hours. In community or in healthcare associated in hospital or after 42 hours. It can be nosocomial, hospital acquired, and ventilator assisted pneumonia, associated pneumonia. So types: you have typical pneumonia and atypical pneumonia. Typical pneumonia, you have causative agents of Streptococcus pneumonia, Haemophilus influenza, gram negative or rods, Enterobacteriaceae, and S. aureus. Staphylococcus aureus. So organisms is not visible on gram stain and not cultivable on standard blood agar. You have mycoplasma pneumonia and chlamydial pneumonia. These are atypical, they cannot be cultured. You have chlamydial psittaci and corynebacterial burnetii. Legionella also. So you have pathological stages: you have congestion, red hepatization, gray and gray hepatization and resolution. So clinical features: you have symptoms: acute onset fever and shaking chills, cough with sputum, pleuritic chest pain which suggests pleural effusion, and dyspnea you have. And in signs you have tachycardia, tachypnea, late inspiratory crackles, bronchial breath sounds, increased tactile and vocal tremors, dullness on percussion, and pleural rub with associated with pleural effusion. So complications: you have circulatory failure, you have septicemia, you have empyema, and acute respiratory distress syndrome, you have metastatic disease like meningitis and arthritis, and you have lung abscess. So assessment of prognosis: you have curb 65, confusion, urea more than 7 millimole per liter, respiratory rate more than 30 minutes, BP less than 90 by 60, and its age more than 65 years. The score is 0 in outpatient, 2 means inpatient, and 3 or more means you have to do intensive care unit. So age more than 65, confusion, the 7 millimole, respiratory rate more than 30 per minute, very much high, tachycardia, and more than less hypotension, BP less than 90 by 60. 7 millimole, 30 per minute, BP less than 7 millimole, age 65, confusion. Okay, so investigations, you do sputum examination, you have gram stain and culture, blood culture you can do, examination of pleural fluid you can do, chest x-ray, PCR for atypical organisms you can do. Management: you have to provide appropriate antibiotics and you have to treat the complications. It is treated by pneumococcal vaccine. Lung abscess. Lung abscess is localized infection, suppurative necrosis of lung tissue more than 2 cm in diameter. It is caused by aspiration of organisms, acute necrotizing pneumonia, or hematogenous spread from distant site. Suppurative necrosis of lung tissue more than 2 cm. Then causative organisms, you have oral anaerobes, and other bacteria. Oral anaerobes, you have Prevotella, Leptostreptococcus, Fusobacterium, bacteriod species. Other bacteria, you have S. aureus, you have S. pneumonia, gram-negative bacilli. Then clinical features, you have cough with this foul smelling in anaerobic infection. You have shortness of breath and fever and chills. Complications, you have bronchopleural fistulas, empyema formation, pericarditis, metastatic infection, and secondary amyloidosis. Then diagnosis, you have chest X-ray wherein you have a thick walled cavitation with air fluid levels. CT scan, you can notice an abscess. Sputum gram stain you can perform. Radioactive indium 111 labeled leukocyte uptake also can be done. So blood count is polymorphonuclear lymphocytes, PMNL. Polymorphonuclear lymphocytes will be seen in the blood. Culture of bronchial aspirate you can perform. Bronchoscopy if there is tumors or foreign bodies suspected. So of course, abscess is there, it can become fistula, it can become empyema, it can spread to pericardium, and metastatic infection, of course. There is metastatic. Okay, metastatic infection, it spreads somewhere else, and amyloidosis can occur due to sensitization with anti-nuclear antibody. Self cells and all, autoimmune basically. Shortness of breath, cough, and fever and chills. That is okay. Blood count you can see. Okay, so treatment, you have postural drainage must be performed, specific culture antimicrobial therapy, and surgical resection in case of resistance to antimicrobials. So IV clindamycin or amoxicillin, clavulanate, penicillin, metronidazole can be done. Hospital acquired abscess, Klebsiella, pneumonia, S. aureus, you give aminoglycoside, cephalosporins, metronidazole, etc. Then we move on to one of the most common disorder, Mycobacterium tuberculosis, which is rod-shaped, non-spore forming aerobic. So transmission occurs by inhalation of aerosolized droplets containing active organism. Only those people with active TB is contagious, and primary TB is not contagious. So primary TB bacilli inhaled and deposited in lung. They are ingested by alveolar macrophages, prevent phagolysosome formation. Granuloma is formed and organism remains dormant within the granuloma. Then you have secondary TB, which is reactivation. Weakened host immunity due to various reasons. Reactivation of dominant TB occurs and it produces clinical manifestation of TB. Then you have extrapulmonary TB, wherein there is impaired immunity may result in dissemination of active disease throughout the body. You'll have TB lymphadenitis, genitourinary TB, skeletal TB, Pott's disease, spondylosis, TB meningitis, TB pericarditis, TB skin, you have lupus vulgaris and sacrophilodderma. Miliary TB, you have acute dissemination of TB in the bloodstream. Then clinical features, you have evening rise of temperature with night sweats, loss of appetite, loss of weight, cough and wheeze, erythema nodosum, which are red tender lesions over the skin and thigh. You have phalantural conjunctivitis basically. And investigations, you have sputum studies, 3 morning sputum studies which takes 4 to 8 weeks to perform. You have acid fast staining, culture LJ media, and polymerase change reaction. So you can have interferon gamma releasing assay, nucleic acid based test, line probe assay, CB NAT, and true NAT. Those are all sputum sputum tests. Tuberculin skin test, you have PPD. You perform, it is a screening test to detect exposure to TB. It is not for diagnosis of active TB. You have chest X-ray wherein the lesions of primary TB can be seen. Grons foci, Grons complex, Ranke's complex, and Simon focus. Grons focus, you have subpleural fibrocaseous lesion in the lung parenchyma, most common site in the lower part of the upper lobe. Then Grons focus and lymph node involvement can be seen in Grons complex. Ranke's complex is Grons focus with fibrosis and calcification. And Simon's focus is tuberculous lymph nodule in lung apex. Lesions of secondary tuberculosis. You have Pehel's lesion. You have Asman focus. Pehel's lesion is supraclavicular lung lesion, and Asman focus is infraclavicular lung lesion. Asman is of course as, so it's down. Pehel is Pehele, which is first supraclavicular. Okay. Ground focus, ground complex, ground case complex, and cement focus. You can see all them in chest X-ray. Tuberculin skin test for previous this thing. It's not diagnostic for acute. 3 morning specimen, which is acid fast staining you do, culture LJ media you do, PCR you can do, but most likely you need to do CBNAT, TrueNAT. Line Pro assay, nucleic acid based test also is okay. Interferon gamma releasing assay is also okay. Then secondary you have Pels and Asman. Then you have miliary primary TB, where there is rich focus. Tubercular granuloma in brain cortex. Weigert's focus is intimal foci in the pulmonary vein, and simian focal is localized foci in liver. But most likely miliary TB lesions you can remember means enough, both enough. That one name, miliary appearance. Okay, so treatment, you have MDR TB, which is resistant to both isoniazid and rifampicin, and extremely drug resistant, which is both resistant to isoniazid, rifampicin, and resistant to at least one second line injectable. So yeah, we move on to first line, which is isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Okay. Group 2, of course, you have canacasin, amikacin. Group 3, fluoroquinolones, ofloxacin, levofloxacin, moxifloxacin, ciprofloxacin. And group 4 is second line oral drugs. These are ethanol is one important thing. I think so. That's the only thing which I can see. Unclear efficacy drug, you have lineage solid. Main important thing. Drugs is also BAPTT procedure. You have bedaquiline, APTT, no, BPT, pitomanid, and linezolid. That regimen is there. Okay, so WHO definition. WHO defines new cases never had ETT, acute tubercular. And had taken EDT for less than anti-tubercular. Once again, tablets, anti-tubercular tablets. These are the new cases. Relapse is previously taken and declared cured or treated completed. However, it is diagnosed with TB. Treatment after failure, restarted treatment regimen after failing, and treatment after default. Return to treatment following interruption of treatment for more than 2 months or more. So, okay, some cases pregnancy, streptomycin do not use. Pregnancy give 2 HRE and 7 HR. Then breastfeeding, you have all ETT drugs are compatible with breastfeeding. Prophylactic isoniazid for 3 months the baby should be given. Beta HCG vaccination should be postponed until end of isoniazid prophylaxis. Vitamin K should be given at birth to mother who was taking rifampicin. So pregnancy HRE 2 months continuous, and HR for 7 months. Basically that's it. Entire pregnancy almost 9 months it is taking. Unfortunate. Okay, liver disorders, you have hepatotoxicity. Pyrazinamide is more than isoniazid, more than rifampicin. Acute hepatitis, you take only streptomycin and erythromycin for 12 months. And chronic liver disease, you give only streptomycin, isoniazid, rifampicin, and ethambutol, and you miss out the pyrazinamide. You don't give Z, you give S. Renal failure, streptomycin and ethambutol are excreted by kidney. Thiacetone is partly excreted by kidney. Avoid these drugs. HRZ and HR. There's no E. That's it. And HIV also you give HRZDS 3 months and HRE for 5 months. Dots. Directly observe treatment. Observe watches the patient swallowing the tablets. Ensures accountability, prevents emergence of drug resistance, and is recommended in all smear positive cases. Then corticosteroid therapy, it may be required in meningitis, in TB of serous sex, and genitourinary TB, and drug control hypersensitivity reaction. It may be required. Then bronchogenic carcinoma. There are various types of lung cancer: small cell carcinoma or wart cell carcinoma, non-small cell carcinoma, squamous cell carcinoma is most common, large cell carcinoma is second, and adenocarcinoma is the third. Then predisposing factors: smoking, asbestosis, occupational hazard, air pollution, family predisposition, history of COPD, scleroderma, sarcoidosis, vitamin A deficiency, and other dietary deficiency. You have selenium, vitamin E, and vitamin C. So clinical features: you have thoracic manifestation and you have extrathoracic manifestation. So thoracic manifestations, you have cough, hemoptysis, dyspnea, pleuritic chest pain, monophonic wheeze, Pancoast tumor, which is superior sulcus tumor, pain in the shoulder and arm, unilateral Horner syndrome, small muscle wasting of the arm, and rib and vertebral erosion. Then you have superior vena cava obstruction like facial and arm edema, jugular venous distension, recurrent laryngeal nerve palsy is there, and dysphagia is also there. In extrathoracic manifestations, you have seizures, neurological deficits, jaundice, and bone pain. Okay, moving on, we have paraneoplastic manifestation. You have endocrine manifestation, wherein you have inappropriate ADH secretion, ectopic ACTH secretion, hypercalcemia due to squamous cell carcinoma, carcinoid syndrome will be there, and gynecomastia can also be noticed. Neurological and muscular, you have myopathy, myositis, neuropathy, dementia, cerebellar degeneration, and Eaton-Lambert syndrome, which is myasthenic syndrome. Similar to myasthenia gravis, it's basically the symptoms are same, but the causation is different. That's it, and it's a little bit better prognosis. Then investigation: you have chest X-ray, you have unilateral hilar enlargement, opacity can be seen, collapse is seen, pleural effusion is seen, rib erosions can be seen, and mediastinal widening and elevated hemidiaphragm due to phrenic nerve palsy. That's all for chest X-ray. Then you have bronchoscopy, and you have sputum cytology, biopsy and histopathological examination, and presence of metastasis, liver function test, isotope bone scan, mediastinum, ultrasound by abdomen, CT, MRI, CECT. All of those can be checked for this thing, spread. So going back, small cell carcinoma, wart cell carcinoma, and non-small cell carcinoma, wherein squamous cell carcinoma is most common. Large cell carcinoma is there, adenocarcinoma is there. So smoking, asbestosis, occupation, air pollution, family predisposition, COPD, vitamin A, and other dietary factors can be seen. So clinical features: you have thoracic manifestation, you have cough, hemoptysis, dyspnea, pleuritic chest pain, and monophonic wheeze. You have Pancoast tumor also, which is pain in shoulder and arm, Horner syndrome unilateral, small vessel weakness of hand, and rib and vertebral erosion. Superior vena cava obstruction is also seen, facial and arm edema, jugular venous distension. Then recurrent laryngeal nerve palsy can be there due to infiltration into them, and dysphagia may be there due to similar reasons. Extrathoracic manifestations: you have seizures from brain, neurological deficits, jaundice due to lung, and bone pain due to bone spread. Superior cell carcinoma. Okay, so paraneoplastic manifestations: endocrine, you have inappropriate ADH secretion, ectopic ACTH secretion, hypercalcemia, carcinoid syndrome may be there, Gynecomastia will be there. Neurological and muscular disorders, you have myositis, Lambert-Eaton syndrome, cerebellar degeneration, dementia, and neuropathy. All of them are due to brain involvement. Metastatic spread to brain. So endocrine, of course, inappropriate age, it's ADH secretion, ACTH secretion. Pituitary. No, actually no. They are all paraneoplastic means they are all secreted by the cancer cell, by CA cells. So they are not actually infiltrated region. All of these are secreted by the cancer cell, but all these features will appear. But it's not due to spread, not due to extrathoracic manifestation. This is okay. Investigations, unilateral hilar enlargement, opacity, collapse, pleural effusion, rib erosions, and mediastinal widening. Elevated hemidiaphragm also may be seen. Bronchoscopy, you do sputum cytology, you do biopsy and histopathological examination. In presence of metastasis, you have liver function test, isotope, scan, same thing. Secondary metastasis, you perform this. Management, you give chemotherapy, you have radiotherapy, and surgical resection. Okay, so another 3 topics are there. So pulmonary embolism. Pulmonary embolism is embolus in the pulmonary vascular tree. Most commonly it is DVT, upper extremity or lower extremity. IV drug users have upper extremity DVT. Risk factors is more than 30 years, malignancy prior history, hereditary hypercoagulable states, vector V laden protein C and S deficiency, antithrombin 3 deficiency, prolonged immobilization like bed rest, long travel, major surgery, congestive heart failure, obesity, nephrotic syndrome, pregnancy, hyperestrogenic state, and estrogen oral contraceptives all are some factors for pulmonary embolism. So pathophysiology, emboli will block a portion of pulmonary vasculature. There is increased pulmonary vascular resistance and pulmonary artery pressure and right ventricular pressure. Blood flow decreases to the area distal to the bronchage, and dead space is formed due to presence of ventilation without perfusion. This results in hypoxemia, hypercarbia. Hypercarbia leads to driving the expiratory effort, and tachypnea will be seen. Okay, so severe large blockade, you have acute cor pulmonale, right-sided heart failure will be seen. So clinical features, symptoms, you have dyspnea, pleuritic chest pain, cough, hemoptysis, and syncope. If there is large pulmonary embolism. So signs, you have tachypnea, rales will be there, tachycardia will be there, S4 will be there, increased S2, P2 will be there, shock, you have massive pulmonary edema in massive pulmonary edema, you have shock, low grade fever will be there, decreased breath sound, dullness on percussion. S4 increases S2, similar to okay, right side heart failure. Okay, tachycardia, tachypnea, rales, S4 is decreases P2, shock will be there, low grade fever, dullness on breath sounds. Dyspnea will be there, pleuritic chest pain due to movement of pleuritic wall, cough, and hemoptysis and syncope in case of large pulmonary edema, because there is blockage of pulmonary vasculature distal to it. Dead space is formed, presence of ventilation without perfusion resulting in hypoxia and hypercarbia. Hypercarbia leads to tachypnea, and sometimes very large means acute pulmonary. Okay, diagnosis, you have to check for arterial blood gas analysis, chest x-ray you have to perform, you'll find atelectasis or pleural effusion. Hampton hump will be seen, western mark sign is there, venous duplex ultrasound can be done, V by Q, ventilation perfusion lung scan you can perform, CT angiogram, CTA, pulmonary angiography, D-isomer assay. All of these are for diagnosis. Then management, you have to administer oxygen, morphine 10 mg IV if the patient is distressed. Heparin, you give a loading dose of 10,000 units, maintenance dose of 1,000 units per hour, and you have thrombolytic therapy, streptokinase, urokinase, pulmonary embolectomy, inferior vena cava interruption, IVC filter placement you perform, and it is indicated in recurrent DVC. You put a filter if you feel that it will occur again. Filter, basically it will filter out the emboli and take it. Pulmonary embolectomy can be performed And thrombotic therapy, you provide streptokinase and urokinase. Heparin loading dose of 10,000 heparin you have to provide. And yeah, streptokinase, urokinase are thrombolytic drugs. I had a similar question on this for yesterday and I could not answer it. Morphine you provide if the patient is distressed. Chest X-ray, Hampton hump, Westmark sign. I don't know. These both, I don't know what they are, so I won't write. Atelectasis and pleural effusion may be seen. Venous duplex ultrasound, duplex ultrasound, ventilation perfusion ratio scan. CT angiography, CT angiography, basically blood vessel, pulmonary angiography, and DISMR assay. Then we have two more topics to cover. One of them is pneumothorax and the other is pulmonary failure. Okay, I'll cover them in a bit as I need to eat something right now. So yeah, see you guys. Respiratory system and then infective. Okay, I'll just finish off respiratory system, and after a while I have to do infectious diseases, and I have to do, what do you say, infectious diseases and geriatrics I'll do. Then after that CNS, there are 3 topics which I want to do, meningitis and stuff like that. I think I'll do it really fast. So yeah, let's get started. First we have pneumothorax. So pneumothorax is defined as air in the pleural space. So there is spontaneous pneumothorax and there is traumatic pneumothorax. Now, primary spontaneous pneumothorax is rupture of apical and subpleural blebs. Whereas secondary pneumothorax is underlying lung disease like COPD, bronchial asthma, TB, pneumonia, cystic fibrosis, histiocytosis, Marfan syndrome, Ehlers Danlos syndrome. The same. Okay. Ehlers syndrome. Then you have closed pneumothorax. In traumatic pneumothorax, you have closed and open. Closed is communication closed. Communication with bronchus is present means it is open. This is bronchopleural fistula. Then you have tension pneumothorax. There is a communication and it acts like a one-way valve. And air enters the pleura during inspiration. However, air cannot escape, which is caused by mechanical ventilation, cardiopulmonary resuscitation, and trauma. Then clinical features, you have it is a sudden onset, progressive dyspnea, cyanosis is there, you have dilated neck veins, you have mediastinal shift to the opposite side, there is collapse of the ipsilateral lung, the same side lung will be collapsed. Then you have hypotension, there is cardiac filling is impaired due to the compression of the great vessels, there is diminished breath sounds, hyperresonant percussive note is present, diminished ventricular fibrillation. Wait 1 second. Vital function test. What is your fit? Mediastinal emphysema may be seen. Then you have investigations, you have chest X-ray where you have lung collapse, mediastinal shift, and air in the pleural cavity. Then management, you manage this by chest compression with large bore needle in the second or third intercostal space in mid-clavicular line, followed by the chest tube placement. Then you have catamenial pneumothorax where it is thoracic endometriosis positive. Females of age 25 to 30 years are affected, and clinical features, you have menstruation associated with repeated attacks of spontaneous pneumothorax, most commonly on the right side. Attacks usually occur 28 before or after onset of menstruation, and there is hemoptysis, that is thoracic endometriosis. So the treatment is ovarian suppressive drugs and pleurodoses. Pleuro, this is, I think it is the same as putting a tube. Okay, then you have clicking pneumothorax. These are small left-sided pneumothorax that may get lodged in front of the pericardium. This alters the heart sound to make them loud and resonant, clicking notes. So differentiating points, you have percussive note. In pleural effusion, you'll be having stony dullness. In pneumothorax, it will be hyperresonant. In hydropneumothorax, resonant over the upper part, stony dull over the lower part. Then upper border of dullness, it is in pleural effusion, it is highest laterally and lower anteriorly and posteriorly. However, in hydropneumothorax, it is straight or horizontal. Lower anteriorly and posteriorly. Shifting dullness is absent in pleural effusion and it is present in hydropneumothorax. Bronchial breathing is noticed. Tubular is above the level of effusion and amphoric with if there is a fistula. It is amphoric in both pneumothorax and hydropneumothorax. So coin test will be negative in pleural effusion. It will be positive in hydropneumothorax and pneumothorax. Successive splash is also absent in this thing. What do you say? Pleural effusion and pneumothorax. However, in hydropneumothorax, it will be present. Agophony and whispering phylloquetry. It is present above the level of effusion. So effusion is there. If you above that, you will be having agophony and phylloquetry, and it is absent in other places. Only in effusion, agophony and whispering phylloquetry is present. Then bronchopulmonary segments. We have three: upper, middle, and lower. And in the left side, you have upper and lower. There is also lingual, but it is technically a part of upper. So in upper you have apical, posterior and anterior. In middle you have lateral and medial, and lower you have apical, medial basal, anterior basal, lateral basal and posterior basal. Basically the same as above, but there is basal added. So posterior is there, lateral is there, medial is there, and apical is there. Everything is the same. One above in the four cardinal dimensions, like this and one above. But in the lower part it is basal. I don't know why there is no basal apical, but it is a problem if you write it like that. So that's it. In middle it is left and right, lateral and medial. You can remember it like this. It will be like this. Okay, then in left side you have apical, posterior, anterior, same as the left side. And you have superior, inferior. Here it is a little bit different. Yeah, it's a little bit repeated over here. Apical is like this, and there is this kind of. There is no right and left itself. A little bit awkward, but I guess you just have to remember it. Apical, posterior. And in lower you have apical, anterior basal, lateral basal and posterior basal. There is no medial. Yeah. I will just draw this. This is for this one, whereas this is for this one. Then there is medial and lateral in the middle. Okay. Lower, there's no medial, that's it. So lateral, this is left side. Okay. This is for lower. Somehow if you can remember, and that you can remember it. Okay, then respiratory failure. Respiratory failure is inadequate oxygenation of blood or inadequate ventilation, where there is elimination of carbon dioxide or both. Criteria for respiratory failure is hypoxia or hypercapnia. PCO, partial pressure of oxygen less than 60 mm of Hg, partial pressure of carbon dioxide more than 50 mm of Hg. Causes: you have CNS depression, you have drug overdose, stroke and trauma. Neurovascular disorder, it is myasthenia gravis, polio, GBS, AML. Upper airway, it is foreign body stenosis, spasms and paralysis. Mechanical restriction, you have kyphosis, flail chest, hydropneumothorax, hemothorax. Then CVS and blood, you have congestive heart failure, vascular disease, and what do you say? Pulmonary embolism and anemia. Lower airways and alveoli, you have asthma, COPD, pneumonia, ARDS. Okay. Causation due to sinus hypertension, drug overdoses. Yes, there are some drugs which will induce respiratory distress, stroke, and trauma. Is there? Neuromuscular diseases, you have myasthenia gravis, polio, Guillain-Barré syndrome, acute myeloid leukemia. And upper airway, you have foreign bodies, stenosis, spasms, and paralysis. Mechanical restriction is kyphosis, flail chest, hemothorax, congestive heart failure, muscular diseases. Congestive heart failure usually leads to respiratory distress. Respiratory failure, my bad. Lower airways, you have asthma, COPD, acute respiratory distress syndrome. Yeah. Okay, so types of respiratory failure, there are technically 4, but main 2 are type 1 and type 2. Type 1 is hypoxemic respiratory failure. Type 2 is hypercapnic respiratory failure. So next we move on, type 1, type 2. So acute, it is partial pressure of oxygen is decreased, partial pressure of carbon dioxide is same. In chronic cases, partial pressure of oxygen is slightly decreased and everything else is same. Hypoxic respiratory failure, like asthma, edema, emboli, ARDS, pulmonary fibrosis. In chronic, like emphysema and lymphatic carcinomatosis. Then type 2, there is hypercarbia, partial pressure of oxygen decreases, pH will decrease, bicarbonate level will be same, because you can assume it like it hasn't been there for a long time, so the compensating mechanism will take time, so it's the same. Example, acute epiglottitis, severe asthma, and respiratory muscle paralysis. Whereas this is edema, embolus, ARDS and stuff like that. This is obstruction, mainly obstruction, inability to pass the air. So carbon dioxide partial pressure will increase in the blood gas analysis. Then in chronic, the same thing, oxygen will decrease, carbon dioxide increase, pH will be less or normal because there is compensation by the bicarbonate. This is chronic bronchitis or blue blotters. Pink puffers are type 1, blue blotters are type 2. This you have to remember. And going on, we have primary alveolar hyperventilation. Maybe there is a pathology due to which there is alveolar hypoventilation. So oxygenation, ventilation versus oxygenation. Here the ventilation is monitored by partial pressure of carbon dioxide. In order to decrease the partial pressure of carbon dioxide, you have to either increase the respiratory rate or increase the tidal volume. Minute respiration is respiratory rate times the tidal volume. Then oxygenation is monitored by oxygen saturation and partial pressure of oxygen. In order to decrease the partial pressure of oxygen in a ventilated patient, you either decrease the FiO2 or decrease the positive end expiratory pressure. So note, ventilation and oxygenation are unrelated. Oxygen saturation may be 100% with a very high PCO, partial pressure of carbon dioxide, and patient can still be in ventilatory failure. Okay, the blood oxygen may be proper, but ventilation might be very much less. Perfusion and oxygen may be is related a little bit. Pathophysiology. So you have ventilation perfusion mismatch. This is what happens. So if there is a defect in alveolar ventilation, pulmonary edema, or defect in alveolar perfusion, response there is response to supplemental oxygenation. Because ventilation is a problem, you give more oxygen, there is a response. Then shunting. This occurs if there is decreased ventilation in the perfused area due to collapse or fluid-filled alveoli. So venous pressure is shunted into arterial circulation without oxygenation, and it is not responsive to supplementation of oxygen. Shunting has no this thing. If there is shunting, there is no response to supplementable oxygen. Hyperventilation, this leads to hypercapnia and secondary hypoxemia. Increased carbon dioxide production, you have sepsis, diabetic ketoacidosis, and hyperthermia. Diffusion impairment, wherein you have hypoxemia without hypercapnia. So clinical features, you have symptoms of dyspnea and cough, and signs, you have use of accessory muscles of respiration, tachypnea, tachycardia, cyanosis, and impaired mentation due to hypercapnia. So of course, dyspnea, cough is the symptoms. Signs, you have accessory muscles of respiration, tachypnea, tachycardia, cyanosis, and impaired mentation. So diagnosis, arterial blood gas analysis, you have hypoxemia where there is ventilation perfusion mismatch, you have intrapulmonary shunting and hypoventilation. Hypercapnia is there and hypoventilation is there. Arterial pH leading to respiratory acidosis occurs in case of hypercapnia. Chest X-ray or CT scan can be done, and complete blood count and metabolic panel can also be done. So partial pressure of carbon dioxide level, it's either elevated or not elevated. So elevated, is it a gradient increase or hyperventilation? If there is a gradient increase, then is the lowered partial pressure of oxygen improved with supplemental oxygen? If it is no gradient, is the low inspired partial pressure of oxygen caused because of hypoxemia? Give me a second. Appaje? ಏನಿಲ್ಲ ಯಾರು ಬಂದ ಕೇಳಿದ್ರು ಅಷ್ಟೇ. ಓದ್ತಾ ಎಕ್ಸಾಮ್ ಓದ್ತಾ ಇದ್ದೀನಿ. Yeah, sorry about that. Okay, so you have first of all partial pressure of carbon dioxide level. You have to check if it is elevated, then there is hypoventilation. If it is not, okay, let's finish hypoventilation first. If it is elevated, there is hypoventilation. Then it asks if there is a AA gradient. If there is, then it is a hypoventilation alone does not account for hypoxemia. There is another mechanism which is present. If there is a alveolar arterial oxygen difference. It is normal when there is hyperventilation is a cause of hypoxemia. It is increased in most other causes. So if there is a pathology, then it is not hypoxia due to hypoventilation. Hypoventilation alone accounts for the hypoxia. Okay, if there is PA carbon dioxide level is not elevated and is the AA gradient is not increased, then the cause is hypoxemia, low partial pressure of carbon dioxide oxygen in the atmosphere. Low PaO2 is a cause of hypoxemia, and if it is, then there is you have to ask if there is lowered PaO2 improved with supplementation of oxygen. If the lowered partial pressure of oxygen is improved with supplementation of oxygen, then it is a ventricular perfusion mismatch. If it is not improved, then it is a shunt. The same thing which we spoke about here. Pulmonary edema or some defect in alveolar perfusion is there, then it is responsive to
supplementary oxygen. If there is only shunting, decreased ventilation in the surface area due to collapse of area, it is shunted without oxygen. It is not responsive to supplementary oxygen. Then you have management. Management, you treat the underlying disorders. If it is bronchodilators, corticosteroids, antibiotics, you provide them. You provide supplementary oxygen. You use lowest concentration of oxygen that provides sufficient oxygenation to avoid toxicity. Then you have NPPV, example CPAP or PIPAP for conscious patient. So you have absence of voluntary respiration, you intubate, and that is how you manage the patient. You intubate, you provide positive pressure, non-penetrating positive pressure or something like that. Wait, you give CPAP and BIPAP, positive airway pressure, control positive airway pressure, and biphasic positive airway pressure in conscious people. I think NPPV is I don't know probably. Okay, you provide supplementary oxygen if it works. Lowest concentration that provides enough oxygenation to prevent oxygen toxicity, and you treat the underlying disorder, bronchodilator, corticosteroids, antibiotics if there is like asthma and stuff like that. Okay, then we move on to cystic fibrosis. It is an autosomal recessive disorder. Defect in cystic fibrosis transmembrane conductance regulator protein. Cystic fibrosis transmembrane conductance regulator protein gene. So CFTCR is located on 7q. If there is deficiency, there is decreased activation of chloride channel. There is reduced movement of ions. Okay, so clinical features, you have respiratory features here, gastrointestinal features, you have reproductive and skeletal features. So respiratory features, you have bronchitis, bronchopneumonia, bronchiectasis, lung abscess, AVPV, atelectasis, sinusitis, polyps, hypertension. Almost every single topic which we have covered just now, because there is the defect of the movement of ions only is defective. In cardiovascular, you will be having cor pulmonale and congestive heart failure. In gastrointestinal, you will be having volvulus, atresia, prolapse, interstitial fecal infection, pancreatic nutritional defects, steatorrhea, diabetes mellitus, recurrent pancreatitis, hepatobiliary, atrophic gallbladder, cholelithiasis, bile salts, reproductive sterility will be there, demineralization of the skeleton will be there, hypertrophic osteoarthropathy will also be there. So complications, you have recurrent respiratory tract infection, pneumothorax, hepatobiliary, you also have focal biliary cirrhosis and portal hypertension. In complications, recurrent respiratory tract infection will be there, pneumothorax will be there, massive hemoptysis will be there, respiratory failure will be there, cor pulmonale and APPA will also be there. So it can be primary ciliary dyskinesia also, which leads to bronchitis and stuff like that. Young syndrome also, where you have azoospermia, sinusitis and bronchiectasis, where this sweat chloride valve will be normal, however. Okay, so investigations you can do chest X-ray, you'll find hyperinflation and mucus impaction, sweat chloride test, which is there will be increased in sweat chloride more than 70 milliequivalent per liter. If there is an increase in the sweat chloride, then it is cystic fibrosis. Okay, pulmonary function test also you can perform and see if there is any problem. Chest X-ray, hyperinflation, hyperinflation, mucus impaction. Mucus and all does not get cleared properly. Treatment, you give pancreatic enzyme replacement, whatever the pancreatic enzyme, if there is a deficiency, because there is a nutritional deficiency, you provide the specific enzyme replacement. Fat soluble vitamin supplementation you provide for the same reason. Vaccination against influenza and pneumococcal, because they are not cleared very easily. Appropriate antibiotics you have to provide. Inhaled recombinant human deoxyribonuclease, DNase, inhaled recombinant human DNase. Okay, I'm not sure exactly why, but I think you go. Mucolytics like acetylcysteine, because it clears the mucus, and hypertonic saline inhalation to again help in clearing of the mucus and stuff like that. And that's it. I'm done with the entire book. Yeah, that's this is all I wanted to do in these two videos. I wanted to explain literally everything in general medicine to you guys, and I achieved my Cool. So yeah, thank you for checking it out. It means a lot to me. It might not mean anything to you guys, but it means a lot to me. So yeah, thank you. I'm going to end this stream and I'll start another stream, but this time I will teach from Archit Balu. I will teach Archit Balu and some other stuff. We can look forward to it. So yeah.